So very good morning to one and all. And as we come on the last day of this exciting WIROC MAX, and we are going to start the morning session on time, and that is in Hall B, which is Fixing the Young TC. I would be liking to call the chairperson for the session, Dr. Maruti Lingayat sir and Dr. Yogesh Vaidya sir. Please do come on the dais and start the proceedings. Thank you so much.
Good morning, those who are here. Let's kickstart with our symposium. I welcome chairpersons, my dear friend Maruti and Yogesh Vaidya. May I request all the faculty to come. GS Kulkarni sir is already there. Avinash Date, please come. Samarth, Mittal, please come. Sachin, Bhat, Atul, Shrivastava. And may I request my co-convener, Bibhas, to come and join me here, please. If not, let's have fun between amongst us. And me and Bibhas will shoot questions. Feel free to stop my aggression if you think I am being more aggressive. We are going to learn about various permutations and combinations, need of fixation. We need to know the current thought processes. We need to learn the disparity, which will be very well seen amongst ourselves. And we also need to choose the rational option. Hey, can I have a presenter view here? Thank you. So the rules of the game we all know, so I am not going to reiterate on that. These are various permutations and combinations which we all see day in and day out. So I am going to pick each one of this permutation and suggest you to start talking about it. Let's start with this. Samarth, you start. So this is a 54-year-old gentleman. He had a recent CABG, young guys CABG with chronic renal failure. He is in ICU and I have been called to look at his hip pain. What do you see here and how would you evaluate? Pick up the mic.
I think I see a small fracture line just medial to the calcar. So I see a subcapital sort of a fracture line in the just inferior portion, but I don't see the fracture line complete at the top. So I would like to get a CT done for this patient.
Okay, Sachin, do you think CT is going to be adequate for this?
Also a lateral view if possible.
Lateral view. Bibhas, CT and a lateral view, any addition or subtraction?
No, I just like a better X-ray actually.
Okay, this is what we have. This is a good quality X-ray, possible in ICU.
Right. Then a CT possible.
Avinash?
Lateral X-ray and MRI. MRI is more sensitive.
Okay. Atul, you want to add something?
I think a CT would do.
CT would do. Okay. So let me stop there. And this is what happened. So nothing was done. And of course, nothing was possible because the patient was bedridden. In 6 weeks' time, this happened. And in 9 weeks, by the time, the whole thing was more clearer, this was happening. So if we get back what I missed on day one, if I would have treated it earlier, suspecting that bedridden patient, and maybe that time I would have, gotten him fixed. So what do we do for such a ICU bedridden patient? What should be the protocol? MRI is the standard of care, not CT, not lateral view, just order for his MRI, and it's proven beyond doubt that MRI in such patients is better to clarify these occult fractures which are not easily seen on X-ray. So that's the science, and that's what we should do. Let's move on to the next one. This is a 45-year-old gentleman, Yogesh.
It's a case of a transcervical fracture neck femur with a more of a vertical fracture line.
Okay.
And I would also like to have his lateral view X-ray.
Okay, given this situation, what will be your take? You will fix this, you will replace this.
It's a 45-year-old patient. I would also like to know what are his occupational demands or what is his kind of a lifestyle. Because I personally feel 45 is a bit of a gray zone area. So we can, considering the kind of implants which we have nowadays, we can also offer him the option of arthroplasty.
So what is the occupation? You will choose arthroplasty at the age of 45 in India?
I can give him the option if he wants a one-stage kind of a...
Maruti, 45, India.
So if it is a 45 years, Indian people, they are usually active people.
Yes.
So I like to go osteosynthesis.
Choice of implant?
DHS with derotation screw is also.
Okay. GSK sir, choice of implant. I know in your case.
Now
the
we need a lateral view.
Yeah.
And we have to something, it doesn't look like a straightforward. We have to rule out some other conditions also.
Sir, kai nahi. No hidden agenda here.
He's just a plain.
He is a plain, simple, fit person. What will be your choice of implant?
A choice of implant would be my own method of fixation,
So I will come
which
to
I
that.
will talk to you.
Okay, yeah.
But DHS and derotation screw would be the idea.
Samarth, this is what I ended up doing. That's 3 months post-op. Do you think this is adequate in this particular case?
Sir, in this view, it looks good. We need to see a lateral view as well to see if there is any angulation.
No, again, I'm telling you, if I'm not showing, there is no hidden agenda.
Even though this is not my preferred screw trajectory, three screws from top to down, I would use an inverted triangle configuration, but it looks good to me, sir.
Maruti suggested, no, stay with you. Maruti suggested DHS and a derotation screw. Don't you think this is a better construct implant-wise, biomechanically stronger for such a fracture?
The DHS with derotation screw, I think by literature is one of the strongest constructs for any neck femur fracture. But whether that is required or not, I would, my preference for DHS with derotation screw is more for basicervical fracture rather than transcervical or subcapital fracture.
Okay, I will illustrate this further. So this, I will come to you. I will come to you. Don't worry. So such fractures, CT scan gives us more and gives us more information in terms of rotation and displacement of femoral head. So that's what the point we are trying to make here. And once you know the rotation of femoral head, and once you reduce it so well, and what you see on the image intensifier in AP and lateral, and if you are able to achieve this kind of reduction, then implant is actually your choice. You choose best of the implant in your situation, and of course DHS and derotation screw as of now available everywhere is the choices of implant. Maruti, you wanted to suggest something?
Last X-ray you are saying that it is a type 2, type 3 bowels.
Yeah.
So in this case, you have to give a vertical shear strength is good with the derotation screw.
We will
and
come.
angulation strength is also good in the derotation.
Completely agree, and we will come to every aspect of this fracture neck of femur. Don't worry. So here DHS was.
I would like to add something. So take, as you suggested, we take routinely CT scan, and you take from above view so that you will know how much is the rotation required. You can draw the line and you measure the angle of rotation, right? You take this view of the CT scan 3D so that you can know how much to rotation. That is very, very important.
Yeah. So the point which GSK sir is trying to make is the validity and importance of CT scan. It might appear that it is an overkill today, but we will come to, over the period of next few minutes, how it is not an overkill, even considering today. So even if that DHS plate is not fitting onto the shaft, doesn't matter as long as some valgus is there.
One more point is that now three cancellous screws are almost out.
Completely agree.
Absolute.
Yeah.
Because now even United States, who was very strongly in, they were through three screws, but they have also now changed.
Yes.
So today, the comparison between three screw is now not necessary.
Yeah, okay.
It is the DHS and a derotation.
Agree. So let's look at this. Sachin, you take this. This is what he presented. 44-year-old gentleman, trivial fall. What would be your strategy?
Yeah, this looks more like a vertical vowels 3. So,
Sorry, go
Yeah.
again. I lost you.
yeah, this looks more like a vertical fracture.
Uh-huh.
So, I would prefer a horizontal screw and then a construct. Reduce it, of course, anatomically, reduce it anatomically.
Okay, so let's say this was done. Are you happy with this? DHS and a derotation screw. All of us agreed that this is the strongest implant. And this is the quality of reduction in AP and lateral.
This looks good on as a post-op X-ray, but vertical fractures usually tend to loosen after. So there's always a dilemma in such.
Bibhas, you have seen this. So I'm going to pin Avinash down on this now.
Fixation wise, basically it looks undisplaced fracture in third image. So it's an incomplete fracture. It was fixed, but the collapse seems to be more than what it should be on the postoperative X-ray in AP. So I don't know, there is something more to it than just the undisplaced fracture.
Obviously, I'm showing, so there has to be something. But do you foresee any problems though?
Basically the long screw of the DHS, and it is likely to collapse. It is likely to cut out superiorly.
Okay, Atul? Atul, I will show you.
One thing very noticeable in this is that
This is what has happened, Atul.
yeah.
So, what do you think?
So the previous X-rays were showing something different. I mean, in that the bones were looking very osteoporotic for his age. But
He's young, 44 years.
But for his age, if you go to the X-ray back and see the lateral view, the cortices and the canal, and even the area looking very, very osteoporotic. But this one is fine.
No, believe me, this is the same patient. I have followed him up. So, if you look at the configuration of DHS screws, that's the same patient. So I'm
Yeah,
showing you the same patient.
that looks fine. That looks fine. But personally speaking, I would do a technique which I am very familiar with now in these particular fractures, and that is the BDSF.
Okay. All right. So, let's say this is the patient who has come to you, Yogesh. Patient has now pain. Okay. So, the scenario is fracture neck of femur fixed well, and now some collapse and now hip pain.
I think I would like to get a CT scan done at this stage, just to know whether there is any cutout over there.
No, there is no cutout. You see on the lateral, there is no cutout. Maruti, why should there be any pain?
It is unusual to get avian changes in the 2 month. It will just undigestible. In 2 months, it is very early to get a. Second, did you fix later on? It come to you old neck femur neglected like that?
No.
It is fresh one.
Fresh.
One.
As I said, I am a very simple man. I have no hidden agenda. I will show you what I have shared.
Even the literature also says that even you do a DHS with derotation screw, there is 20 to 30% failure rate is there in the neck femur fracture. Even in spite of do anything, there are chances that you will get such. And if you are showing the avian, then it's okay. Pain is the cause of the pain is avian. But if not avian is there, then one has to suspect infection also in that case.
No infection. GSK, sir?
No, as he suggested, there are 30 to 40% complication rate. It's a well done DHS and derotation screw. It is done well. well reduced, well fixed, nicely fixed, everything is okay, but still it is likely to.
Perfect. So 25%, irrespective of whatever you do, because of the initial injury and displacement, what happened during the, so that will cause in 25% of the patients, despite of you fixing it fantastically well, will have pain and will land up into AVN. The point which I am trying to bring out is what we should do at this, GSK sir. Remove the implant or do a THR, because patient has terrible amount of pain.
Yeah, now I think it is better to do a arthroplasty.
Arthroplasty.
Because I don't will improve with any improvement today. On day one, you should have done something else to prevent this. Is why I will ask you now, why this has failed?
So, again, as I said, initial injury should be evaluated still more in terms of CT, in terms of displacement, in terms of posterior tilt, and in terms of fixation.
We have done it well, very well done.
So, irrespective of that, 25% AVN would happen.
Why?
Injury.
No. My hypothesis is that it is the sliding which is the cause of failure. Because there is a vertical shear force, steering force is there. This will not be prevented by this because there is good compression and the compression has to be maintained during the post-operative.
So, if the implant would have been better, this would have been avoided, probably.
Yeah, the problem is avoided. You have to reduce the shearing force, increase the compressive force, and during the post-operative period, you should have compression to be continued till healing. And also today, chemicals are needed, injection teriparatide, and yesterday
Bisphosphonates.
I
Bisphosphonates.
discussed with denosumab. You combine DHA this with denosumab and injection teriparatide and prevent sliding and shearing force.
Samarth, patient has come now to you fresh, operated by me, and he has come to you now for pain. What will you do?
But to me, it looks like it is probably avian, early avian, and some of these patients get a lot of pain because of the shortening of the neck as well.
Yes.
So I have to evaluate how bad is this pain. If it is very bad, then I need
Very
to
bad pain.
Then I would remove this implant and do a total hip, sir.
And do a total hip.
Yes, sir.
Same sitting.
Same sitting, sir.
Can I add?
Sushrut, what is the cause of so
See,
severe
now,
a pain?
if it's
so
45
severe
years,
pain?
45 years old and is old, one chance you can give is the valgus osteotomy.
What is the cause of so severe a pain at 2 months?
Happens.
Are we labeling? It happens, but what is the real cause?
Avian. So the point which I am trying to make is different. So let's. Okay. Mike.
Stage 2 or stage 3.
Okay.
We have seen many patients of avian, they are not so painful at this stage. And it is just 2 months, you say that.
I will demonstrate the point, and this is Avinash's case. So this is what he received, Avinash Date's case. This is what he received, and he fixed it so well. Fantastic implant. And GSK sir. So this is that patient. Another patient, I'm just trying to make it a point.
Yeah.
So this is a 59-year-old lady.
This synthesis we have used.
So this is FNS.
FNS.
So FNS. And Avinash's case, I am representing him. And this is a good modern implant which caused the compression on table, locked on table. And the point which you are trying to make, he did everything to prove that point using a modern device available to every one of us. And I'm going to go further. That's what happened in 9 months, and that's what happened in 1 year, 9 months. Now patient has pain. What he should do?
Now I'd like to add something about FNS. FNS is just a modified DHS, nothing more.
So Mike.
It's just a modified DHS, nothing more. It has the advantage that it is a small one and he has got this That is, it prevents to some extent sliding is prevented because there is angulation. It's not two parallel, it's angulated. So there is a possibility of a sliding. These are the two advantages. Otherwise, it is just like.
Okay, so we talked about the implant, and I agree with GSK sir today that FNS is a wider DHS. The results are yet not out. We have used it for 6 months, 1 year, 1.5 years. We will see, and let us see what it proves to us. I also like this implant because it's easy to do, available, technically very phenomenally easy to achieve. But this is what has happened. Samarth now, the similar case. Here also avian, the previous case which I did DHS derotation screw, also avian.
Yes, sir.
What should he do? Should he do removal of implant and THR same sitting?
I would do a THR at the same sitting, sir, because there is a good amount of avian. I don't think this is going to improve with anything.
Sachin,
Yeah, THR same sitting.
Bibhas, same sitting. Avinash, I know what you have done. Atul, Yogesh,
Implant removal and THR. Team sitting.
Maruti. Okay, so GSK sir, me एक second सांगतो. What happens is avian happens. There is a antero-superolateral sector which gets involved. Your implant is actually holding it, so it is not collapsing in some situations. Pain is there because of avian. The moment you remove the implant, for some time the pain will disappear because the compartment will get released. And the pain will disappear for some time till the time he shows up again with a massive collapse and a requirement of arthroplasty. You can stage your thing. But Avinash, the point which you made in this case is remove the implant and the pain. So what happened, Avinash? Tell us the story of this patient.
Basically, even though there is AVN, there are a lot of varieties. What happened after AVN? If there is no chondrolysis, if there is the cartilage is intact, basically the patient doesn't get much pain, even though there is a lot of collapse. And in this particular situation, even though there was collapse, the hip movements were pain-free. I removed that implant and put the cement in the place to prevent the collapse, so that basically the further collapse doesn't happen. So that's what I.
One more point in this case is there is a tremendous shortening of the neck. And so the abductor mechanism is disturbed and the patient has got a bad limb and that also will cause pain in future.
Okay. So
And don't you think putting the cement would hinder the later THR?
No, I agree, Atul. I completely agree. I would not do it, but this is one more point which I wanted to bring forth. That some people remove the implant, some people put in a fibular strut graft, some people put in cement, some people do same time, same sitting arthroplasty, which is also absolutely rational because someday or the other he will land up with arthroplasty for sure. I will bring out some more experiences. So this was another case of mine. Young guy, I thought reduced well. That's 3 months down the line. Again, I was observing the patient. That's 2 years down the line and collapse. And finally, cut out. So he was a 39-year-old guy who is with good bone stock. Still, shit can happen. So even though it can be a sclerotic thing, the implant can just pierce through and the ultimate truth is going to be this. So we all as surgeons must know whatever we do in 15 to 25%. Depending on what implant we use, we can reduce it to 15%. But we cannot make it 0% as of now in the world. So 25% with the conventional implants, 15% maybe because of whatever GSK sir is saying, using those principles, we can bring that 25% to 15%. So our struggle is to bring down those 25% of complications to 15%, and that's what we all do. So what's the current concept? What's the current thought? So that's what I Googled. Should we remove the DHS and collapse of femoral head? So the verdict is very clear that do not remove the implant. it will land up with collapse. It will land up with total hip replacement. So don't remove the implant till the time there is an infection or implant failure. Only for patient coming to you for pain, unless until you are planning to do arthroplasty, don't do it. That's the verdict. Okay, next case. Impacted fracture. Samarth, back to you. What would you do? 56-year-old gentleman.
Sir, I would get a lateral view and a CT scan done in these patients.
Okay, so let's see, I have done this. Are you happy? Same patient?
The AP view looks good to me, sir. In
Lateral?
the lateral view, I see some angulation towards the posterior. So I think there is 10 to 15 degree of posterior angulation still left, which is common in these valgus impacted
No,
fractures.
if you, so that's my patient and I have done it. Look at the lateral. You're not happy with this?
I think it is slightly, it has a slight posterior angulation. to
Okay,
it.
so the point which I am trying to make, which GSK sir just brushed, is if this is the patient and a valgus impacted fracture, you think these are rotationally not very unstable. They are rotationally stable fractures. But if you really look at the CT scan, sir, तुम्ही हा CT scan view म्हणत होता. So this is the CT scan. Looking from the top, it will give you the amount of posterior tilt.
Yeah.
And you can actually measure that posterior tilt, how much it is. And in this particular situation, which was the X-ray which I showed you Samarth earlier, required an open reduction. And I had to do it open, correct this amount of posterior tilt because it was 35 degrees. So why this big fuss about posterior tilt today is because this has to be disimpacted. This has to be corrected fully, otherwise they collapse and they land up with AVN. So posterior tilt has to be corrected and then fixed, and this is the same patient.
Yeah, this is very, very important that CT scan 3D will give you how much is the rotation. That is very, very important point. Everybody must understand this. CT scan is a must because of this.
And this is the view which we should ask our radiologist to give us.
So this lateral looks better to me, sir. This looks absolutely fine, sir.
Same patient.
Sorry about the lateral.
No, don't worry. I'm just trying to bring out various points. So the statement which I'm trying to make is valgus impacted can be conserved and undisplaced, and what we think are valgus impacted must be evaluated well and cannot be conserved. Going back again, valgus impacted which can be demonstrated on CT can be possibly conserved, and undisplaced fractures which we think are in valgus cannot be conserved, though we think that the X-ray on the right is impacted. And someone would be tempted to conserve this, should not be conserved, because what happens is, though this is impacted, our patients don't always listen to us, and this is what happens. Sachin, what's your take on this? How do you manage such patients? So let's say it is an impacted fracture, and what do you instruct your patients? Because my patients tend not to listen to me. म्हणजे तू सांगितलं सुद्धा की चालायचं नाहीये, they will after 1 week come walk into you.
Yeah, they will not listen to you.
So what's your take on this?
This is at 6 weeks.
So it's no, I'm telling you first X-ray. What would you instruct your patients so that 6 weeks thing doesn't happen?
Be absolutely non-weight bearing and lie down, but it's very difficult in this day and age to.
Bibhas, any suggestions for such patients?
I would fix it straight away.
Fix them. So there is no patient, Bibhas, in your books not to fix. All patient gets fixed. Fixed.
No option at all.
No options.
Yes.
Avinash?
If it is young active, fix it. Yes.
Fix it. Atul? Fix. Yogesh?
Sir, would not have conserved this patient.
No. Okay.
I would fix this. If it is not rotated normal, everything is normal, I will fix it. But it's one case in which I use 3 cancelled.
Correct. So that's the point which I was coming to, that these are the only patients who can be probably treated by cancellous screw. Because this is well impacted, undisplaced on day 1, patient is not going to probably opt for major any surgery. So,
Why we should not use DHS is because when you are tightening the last tendon, they get displaced. That is a big problem of DHS. The last few steps you want to turn, then it gets displaced. And in this case, if you displace, then it will become a non-Indian. So this is one case in which DHS should not be used.
so the distinction between these two is vital. That's what the point which we are trying to make, impacted and undisplaced. Let's go to this very fantastic fracture, vertical fracture line, Samarth. What will you do?
In Powell's 3, obviously after getting an X-ray CT scan done, understanding the fracture, I fix these fractures at less than 60 years of age. I would use a FNS for these patients.
FNS. Okay. This was done. Sachin, any comments?
The EP looks good. The lateral, it looks good, but I think the placement of the screw is slightly, can't see the...
In this case, I was fascinated by North Americans and I replaced my terminally threaded with a fully threaded cancellous. So there was a phase in my life that I would replace all my derotation screw with fully threaded cancellous. And despite of probably good fixation, this landed up with some collapse. But anyway, the point which I'm trying to make, Sachin, stay with me. So that's the vertical fracture line. CT was showing this amount of displacement. Again, there was a phase in my life when I was using angled blade plate for such fractures. And that's what I did. And it stayed well. But let me ask you, this is the patient, vertical fracture line now. What is the current, forget about the shaft of femur. Let's focus only on neck femur, Sachin. What would you do? Choice of implant?
Reduce it anatomically and FNS.
FNS. Bibhas?
Yeah, I would still opt for a DHS with a derotation screw.
Okay. Avinash, any tricks?
Choice of implant according to literature actually is intertan, because it has good rotational stability. You can compress it on table, biomechanically a very sturdy implant, and these are Powell 3 fractures, so that's what literature says.
Intertan. Okay. Atul?
Can be a good option, but personally I would do a DHS and derotation.
DHS and a derotation screw. And you would do retrograde nail for the shaft femur. Obviously, that's ipsilateral. Yogesh?
Same, sir.
Same. Maruti? Sir?
Sir, this is the vertical fracture. There are only two methods of fixation. One is you can use DHS derotation screw and put a Powell screw. Powell screw, right?
Sir, let me stop you there. So, sequence of fixation. First screw, putla.
First screw, derotation screw. Then DHS, and then Powell screw.
Last Powell screw.
Last Powell screw.
Okay. Samarth? You have chosen what are options?
Sir, first of all, I think in these fractures, even though they look bad, they have a very good prognosis for the neck. Because a ipsilateral neck and shaft fracture, the neck has really good prognosis. Most of the energy, even though the fracture lines are usually vertical, but the energy, most of the energy, if you see, they are always a comminuted shaft fracture. So all the energy of the fracture has gone in the shaft. And more often than not, the moment you take them on a fracture table, they reduce and they have really better outcomes. And it is shown that these neck femurs have better outcomes than isolated neck femur fractures. And they are usually vertically stable. They are usually Powell 3. So despite everything, they have better prognosis. But yes, I would do previously I would have done a DHS with a retrograde nail. Now I would do a FNS with a retrograde nail in these
Okay.
patients.
So, Samarth, I will pin you down on that. There are 4 varieties of ipsilateral neck and shaft. And what you are speaking about is only first variety, which is undisplaced vertical fracture line, which can be treated by a single modern implant like a reconstruction nail and plate. But type 3 and type 4, which are high velocity injuries, wherein even the neck is vertical fracture line and displaced, and a comminuted shaft, bad prognosis of both, and especially one of the fracture tends to go in non-union. So these are the fractures which need independent fixation, always neck femur first, followed by shaft femur. And I disagree with GSK sirs in that the first screw has always to be the horizontal screw to compress the vertical fracture line, and then once everything falls in place, you just execute your DHS and derotation screw. That's 6 months down the line, and that's few years down the line, and that's 7 years follow-up with survival of femoral head. But the credit goes to good reduction of fracture neck of femur and the technique that was used for 7 years. This teaches a simple logic that how that Powell screw should be passed as the first screw. Should it be configuration be floating in the inferior portion of femoral head, or should it have a bicortical purchase? The teaching now is it has to be bicortical fashion so that it has a good axial and stiffness, and it should not be unicortical because that will offer least resistance. So the point here is configuration C is the preferred configuration for vertical fracture line, and then whatever implant you want to use, DHS and a derotation screw, or maybe an intertan, or maybe whatever. So then everything should fall into place. Let's move on to the next variety, bifocal fracture. Sachin. No. Two. So preferably posterior, that has not been discussed, but it has to be posterior because that's the thickest portion of femoral head. So don't over tighten it, otherwise the whole thing will collapse. You have to keep watching your lateral all the time, otherwise posterior tilt will revert back to originality. Sachin.
Yeah, this is the extension into the trochanters. Preferred choice implant would be a nail, EFN or intertran.
Okay, Bibhas. Same. Avinash.
Same.
Atul.
Nail with a side plate, Gonzalez plate.
Okay, so I will go further on this because we have less time now. So that's after traction. This is what is been seen. Yogesh, do you want to change what implant you want to use here?
Probably a nail with a side.
Nail. Maruti? Nail. GSK sir, you also nail?
Plate and nail and plate.
Nail and plate. Okay. So here I chose to have a good reduction, and that was the reduction, and that's what I chose to do. Because again, that was a phase in my life wherein I chose to, since I was opening up and reducing all the fragments together, I chose to do this, and I landed up with this. And most of the bifocal fractures today are better off stabilized by an implant which is probably with this, if there are many fragments and many fragments need good kind of reduction. And so similar to demonstrate what I am suggesting, this is a borrowed case. So this friend of mine, Rahat, had this fracture dislocation. He tried to use this calcar plate, but that was coming in his way of reduction. And again, these bifocal fractures are very difficult and very rare. So I just borrowed this case, but this was what was used. Avinash, next in the spectrum is this scene, which comes very rarely again. So this was a subcapital fracture, fracture acetabulum, femoral head intrapelvic. What would you do?
Right, difficult case. 42-year-old male, obviously we have to fix everything together.
I missed one more information. She was weighing 160 kg. She was huge.
Makes the problem more difficult.
Yeah.
Obviously we have to fish out the femoral head first, and then fix the acetabulum, and then go on to femoral side and fix the femoral head, fixation of the transcervical fracture. So that would be my tentative plan as of now.
Anyone who would differ from this, he is going to go all the way and fix it. Samarth?
Sir, I would explain the prognosis to the patient. I think this has really poor prognosis, and probably these are some of the patients I would consider for fix and do a total hip in the same sitting, sir.
Same setting. Okay. Maruti, anything different? Same. Okay. So let me run because, so I chose to go Samarth way. I extracted the femoral head. I used it as a graft. I fixed the columns, and that's 3 months down the line, and that's 18 years now. Let's look at some newer implants. We have all used all various implants. The new kid on the block is of course FNS because it is supposed to be giving better strength. And of course we have various implants which have been used. And these are various implants that were in our armamentarium. We have seen Avinash Date's case of using very effectively an FNS. But let me borrow GSK sir's case. This was a 45-year-old gentleman which was treated somewhere else, and that was the non-union probably, which after 2 months was showing this, and patient was all right for some time. There is no fracture neck of femur in the initial this thing, and suddenly patient started having pain 1 year after. And this was how he came to sir. I will give you some more information before I ask GSK sir to talk about it. So this is the vertical CT scan which he was talking to us about, which gives more information. Metabolically the patient was all right. So what will you do? Samarth, this is the fracture.
Sir, I'm sorry, I missed the age. Age is?
Young guy.
Young patient.
Young, 44.
So, and this is a stress fracture. And the shaft is united, sir, you said, hypertrophic union. So, I could do a, sir, nail removal here and do a DHS or a FNS, sir, after reduction.
Okay. Anyone different from Samarth? Because then I want GSK sir to talk more. So, sir, your turn now. Tell us what you...
Say, now this case, initially I would have done a valgus osteotomy in case and then retrograde nail. Here we are using what we are calling as a triangular method. That is a very, very absolute, gives absolute stability. This triangle, show the triangle. Yeah, this is the triangle. See, this triangle is a phenomenal, very marvelous implant. This gives you absolute stability to the so we reduce it. If the reduction is very satisfactory, go ahead with a triangular method and fix it up. So this is a new technique that we have developed, and we have done now 30 cases. Of this, 29 have united, 1 has not united.
Okay.
So this is how.
So basically, this gives you the ability. It's a modified DHS, and that's the X-ray result, and that's the function. To me, when I judiciously looked at these implants and I pitched them against each other, so FNS is available to us, and this is something which is slowly coming out in the market by Nebula. To me, when we have to do FNS, we have to really lower down our entry, not center, because our femoral heads are very small as against European femoral heads. And again, to me, this creates only one plane control. It doesn't really give you another plane derotation ability. Whereas the GSK sir screw goes in the inferior portion of femoral head and actually acting as a Powell screw and actually giving a better biomechanical strength. That's my thought process. Let us see for years to come what either of these implants give us in terms of ease of doing, in terms of results. So I think take-home message probably is impacted versus undisplaced fractures need to be differentiated even in young. Neck femur fractures should be treated as intra-articular injuries. Perfect anatomical reduction is a must. Controlled collapse during procedure and then absolutely no collapse probably is the way to go for most of the fracture neck of femurs. We still have 1 minute, so I'm going to push some slides. We know this classification, Powell's and Gardens. Powell's looks at biology, Garden looks at anatomy. We as orthopedic surgeons are just bothered whether it's a bloody undisplaced fracture or a bloody displaced fracture. But CT scan probably is going to add our more looking at the way we should look at them, because the tilt is extremely important, whether it is 0 to 15 only, 15 to 30 or more than 30. Why? Because scientifically now it is proven that more than 15, the chances of collapse and the chances of AVN increase. And that's what we need to rectify to bring down that 25% of complication rate down to 15%, because more than that we cannot really avoid. And so if we add Gardens, Powell's and this city-based classification, these undisplaced varieties are probably the varieties which we can consider cancellous screws. But the moment the fracture goes beyond, we are then talking of maybe open reduction, and DHS and a derotation screw becomes absolute mandatory. But the moment it becomes an area of displaced more than 30 degrees of tilt, then we are talking of converting Powell's 3 to 2, 2 to 1. Absolute anatomical reduction, maybe consider primary valgus osteotomy if that fancies you, and think of newer implants in such patients. Of course, DHS and screw remains as the basis. Beyond that, of course, we can consider. Thank you very much. I thank all the esteemed faculty to be there, and we enjoyed. Thank you. Chairpersons, you want to say something, please?
Thanks a lot for this excellent session. Very nicely conducted, and a lot of knowledge has churned out of this session. Thank you, sir.
Again, thanks Sushrut sir for updating again the newer implant of neck femurs. So there is a lot of literature has to be come on FNS. And initially, GSK sir also used to do the valgus osteotomy for vertical fractures. Nowadays, because of the newer implant and everything, that valgus osteotomy has gone, primary valgus osteotomy. Thank you very much.
Both the implants which you showed, the FNS and GSK sir's implants, are fine. GSK sir's implant might be better in that it's creating a good angle, triangle in the AP view. But in the lateral view, the neck is round. You need to consider the anterior-posterior parts also of the neck. So do you put separate screws for the anterior-posterior parts, or this particular implant, GSK sir for you, goes exactly in the center of your neck? Lateral view. Lateral view madhe sir, center, does it go exactly in the center? Or you consider the anterior-posterior superior here?
The DHS and the, you can see that DHS and the one which goes Powell screw into the head, that is in the dead center. And then you can choose.
You can add screws.
Anterior or posterior. That depends upon the comminution. If there is a posterior comminution, you use the posterior derotation screw. If there is an anterior comminution, you use.
Similarly, Sushrut, what does the FNS have any scope of any anterior-posterior screws? No.
No.
Exactly.
FNS,
So FNS in
FNS
how many?
FNS is fixed. In fact, in lateral, it is dead center.
In how many days does a FNS act as a single angled implant?
We don't know. The result is not yet
Because you
out.
cannot say that it's a double angled implant then.
I understand. And in fact, he brushed upon that point. If there is a posterior comminution in neck femur, almost always there is a posterior comminution. Almost always. So the posterior screw is more important, because that will avoid collapse posteriorly later on.
For that matter, that Atul might be knowing Filippo's technique. Yeah, that is much better probably. But then it's a bit difficult.
It's
doing
extremely
it,
technically demanding. Atul is a great surgeon.
The Agra people, they do a lot. I know.
I will talk on Philippos if there is time. See, Philippos technique is very good. It gives equally good results. But Philippos himself has agreed that it is cannot use in vertical fracture, because the lower screw goes in the way of the tip, and vertical fracture it will not act. he has given a letter to Naik from Bangalore who asked him, so he has given a personal letter that it is cannot be used in vertical fractures.
So there are few centers in India, Gwalior Center, Atul Center, in South India, 2-3 centers, who are using Philippos routinely, but it is extremely technically demanding.
The last thing for the easiest thing with a normal orthopedic surgeon in his normal practice can do is, what they do is a DHS with a derotation.
Correct.
So instead of putting the derotation parallel to the DHS,
It is not parallel anymore.
it should not be parallel anymore.
Yes.
So instead of using it parallel, it can put it in another angle after
Correct.
reducing.
Posteriorly. Yeah. Thank you. Yes. Thank you. No more questions. We have to move to Hall A. Thanks.